We are talking about the role of preoperative imaging in living donor liver transplantation. Liver transplantation is the only effective and definitive treatment for patients with end-stage liver disease. This procedure allows healthy adults to donate a portion of their liver to compatible recipients. Living donor liver transplantation is a radiology-intensive process that involves the performance of CT, MRI, conventional vascular ultrasound, and conventional radiology procedures. Because of the severe complexity of the hepatic resection, preoperative imaging plays an important role in donor selection and surgical planning. The main role of pre-surgical imaging is to provide a vascular, arterial, and venous, as well as a biliary roadmap, which is critical for surgical guidance. You have to clearly mark donor safety is a must. The safety of the donor is a primordial concern in living donor liver transplantation. The undisputed disadvantage is the risk of serious complications or even death in the healthy donor undergoing a partial resection and general anesthesia. This is just simply, as you all know, the part that's being this is usually most of the transplants are right lobe grafts. Anyway, we can see that this is the right lobe. It's usually the most common is that right lobe with a hepatic vein, hepatic artery, portal vein, and a duct. Multi-detector CT in the living donor is a technological advance that permits high speed and high resolution helical imaging of the entire liver volume with a single breath hold. What's our objective? Assessment of the hepatic parenchyma, whether there is fatty infiltration, cysts, focal lesions. Assessment of the graft size, which is called volumetry. Morphology of the arterial system, morphology of the portovenous system, and also it can be used for long-term follow-up of the graft size growth. We do what's called a triphasic Ct, and the idea of having a triphasic Ct is that during the procedure, it's very clear that in the arterial phase, you can only opacify, you should only opacify the hepatic artery as you clearly see here. And then you take from this arterial phase, what we do is that we have an arterial angiogram, is that we take 3D images, coronal and axial, to clearly identify the anatomy of the arterial system, as you can clearly see here. Coronal and axial maximum intensity projection images. And then we can do volume rendering of the images, as you can see really clear here, and we can identify actually the anatomy of the hepatic arterial system. Although it's known for a fact that the anatomy of the arterial system is really not an issue in liver transplant. As they say, they just need an artery to anastomose. And here's the anomalies, the most common anomalies, variants actually, it's not anomalies, variants in the hepatic arterial system. And what's most common is that you have the right hepatic artery arising from the superior mesenteric or even directly from the aorta. The portal dominant phase is that during the triphasic procedure, you have to opacify, you have to clearly identify the portal vein by itself without any other opacification of any vessels, so that you can take a good image. As you can clearly see here, you have a pure portal phase in the procedure. And then what we do is that we do a hepatic photography, is that we do a 3D image in order to clearly identify the anatomy of the portal vein here, and it's very well opacified in the coronal and axial images. And then we assess the portal variants, whether there are not. There are different portal variants, but usually it's 4 types or even 5 types in some schools. And the most common, of course, we know is that Trifocated Portal, in which we have the right anterior or the posterior portal veins arising from the left portal or the common or the main portal. As you can see here, this is the normal portal image. This is a Trifocated Portal, where you can see the right anterior portal is rising from the left portal. And here also is that we have the right posterior from the main portal. And here we see the type 5, in which we have the portal vein. It's one single portal vein draining the whole liver. And this is, to my mind, this is an absolute contraindication for transplant. But maybe the Trifocated, now they have solutions for that. Maybe in the back table, they do anastomosis for the portal vein trifurcation. But it's schools in liver transplant. The venous dominant phase also, you have to clearly opacify the hepatic veins by themselves. And this is now becoming of importance, is to clearly opacify the hepatic veins in order to do a hepatic venography after that, where you can do a volume image and you can see the venous system of the whole liver. And as you usually take the right lobe, you can see the red vein here, which is called the inferior right. This is a volume rendering image, inferior right hepatic vein. And this, according to its size, diameter, as we see here in the image, the surgeon decides whether he's going to anastomose it to the IVC or not. We have the variance, that main variance that we have is the inferior right hepatic vein. And also if you have a challenging vein to the segment 5 or segment 8, that also might, as you see here, that might needs to be anastomosed during the procedure. What are the volumes that we measure? We measure the whole liver volume. We measure the right lobe without the middle hepatic vein. We measure the right lobe with the middle hepatic vein. And on the other side, the left lobe with the middle and the left lobe without. As Dr. Karim said, the GRWR is of great importance. It should not be less than 1, but actually we accept up to 0.9 in our work, but smaller than that is the risk of small for size grafts. It's very important, the residual volume, and to my mind, I consider the residual volume before I consider the graft size. The remnant left volume should not be less than 35% of the whole liver for sufficient metabolic function during regeneration in the donor. As we all agree, the donor safety is the primary concern. This is how we do the volumetry. Quickly, we do it usually manual, but now we're starting to do semi-automated technique in order to measure the volumetry. We do it by assessing the whole volume of the liver, and then we get in from it the measurement of the graft. We do it manually, slice by slice, on 8 or 6 millimeter slices, and then we get the whole volume of the liver. And then we do the right lobe graft without the middle hepatic vein, and we know that the plane of resection should be 5 to 10 millimeters to the right of the middle hepatic vein, and sometimes even less. And then and then we measure the whole right lobe here, and then we wait, and then from there we get the right lobe graft weight without the middle hepatic, and here we get the right lobe with the middle hepatic, where we take the plane just lateral to the middle hepatic or just to the right of the middle hepatic vein, putting in mind that you have to include also the right without and with, you have to include the right portal vein with it. This is the volumetry. Now to an important issue is the liver fat assessment. Preoperative detection of fatty infiltration of the liver is critical as it may be associated with impaired function of the implanted graft. CT is sensitive in detecting fatty infiltration of the liver by measuring the liver spleen ratio, which should not be less than 1 in the non-contrast study. MRI is emerging now as a very accurate non-invasive technique for quantitative assessment of degree of fatty infiltration using the PDFF, which is the proton density fat fraction, and the MRS. Ultrasound is also lately used for quantification assessment of fatty liver using specialized techniques that are vendor related. Meaning the companies, they name the technique. I did not want to mention them so as not to be vendor assessed, but each company has its name for assessing the fatty infiltration quantification, not qualification. But now we are pushing hard, and also of course the liver biopsy, which is the standard technique. This is how we assess the liver spleen ratio in the non-contrast study, of course. And here is assessment of by MRI. And now we are starting a big research now in our institute in order to implement the use of MRI for assessment of fatty infiltration for donors, hoping that very soon we will ask our surgeons to stop doing liver biopsy, whether donors or patients with steatosis or patients with steatohepatitis. And we are starting a big research in order to implement the use of MRI and ultrasound specialized techniques for assessment of quantitative assessment of fatty infiltration. Magnetic resonance cholangiography, preoperative diagnosis of biliary tree anatomic variants with MRI may allow for better surgical planning and avert unnecessary surgery in donors with potential unsuitable anatomies, thereby decreasing complications in donors and recipients. The accurate definition of the donor's biliary anatomy is crucial for surgeons to choose the type of surgery, whether right or left hepatectomy. Biliary complications remain the Achilles heel of live donor liver transplantation, which contributes significantly to post-operative morbidity and are occasionally the cause of graft loss. The risks of biliary complications increase with the number of bile ducts openings in the graft. Non-invasive validation of biliary tracts in living potential liver donors is challenging, owing to the small caliber of the normal-sized bile ducts. MR cholangiography using thick and thin slab T2 weighted sequences has been widely used to detect the biliary tree. Routine preoperative assessment of the anatomy of the biliary tree of the potential donor has been internationally accepted as the standard practical use using MRI cholangiography. Standard practice using MRI cholangiography. However, intraoperative cholangiography will always remain the gold standard technique for mapping of the biliary anatomy of donors, and this is a technique that surgeons usually love to see during this procedure. This is a regular image of the biliary system, as you can see here. But with biliary tree has many variants, but the most common actually it has 6 types of biliary variants. But the most common is having the right anterior and right posterior ducts draining into the left and the common hepatic. And I would say that having 2 ducts now is not a contraindication for surgery, but I think more than 2 ducts, surgeons or most schools don't like to do that, especially that sometimes there are surprises in the OR during intraoperative cholangiogram. This is a clear image here of MRI showing the type 2 where the right posterior duct is draining into the left hepatic duct. And here's also another image with the intraoperative cholangiogram and seeing how accurate the MRI can be. Here's a 3D image showing the common hepatic duct only with one single right hepatic duct. And this is actually from our intraoperative procedures. You see the right anterior draining into the left, which is the same as the intraoperative cholangiogram. And here also we have a short stumped right hepatic duct, which is also the same in the intraoperative cholangiogram, but some surgeons, sometimes these kinds of ducts can turn into 2 ducts in the end in the OR, not just a single duct. So it's actually a single, but ending up in 2. And here we see the right posterior also draining into the left hepatic duct clearly. MRCP in donors is usually a challenging procedure. In conclusion, liver transplantation is a successful therapeutic option for patients with chronic liver disease and liver failure. Preoperative imaging has become an integral part of any liver transplant program for the assessment of live donor liver transplantation. Both multi-detector CT and MRI cholangiography proved high accuracy in preoperative graft evaluation for improving the prognosis of the surgery. Thank you very much.